just want to present you the story of a young lady. She has no medical history, no medication. The only abnormality was that this patient had a lot of sport activity, and she had a cardiac check many years ago. And on the ECG, there was a left bundle branch block. She got at this time an echocardiography with a mildly reduced left ventricular ejection fraction around 45%. She has also some risk factors. She has dyslipidemia, and also, despite her sport activity, she's an occasional smoker. So, as I told you, she's very active. She's swimming or jogging several times during the week. But she complained during the last week she felt less comfortable during the exercise. And I received this lady during one night when I was on call for an acute heart failure with acute pulmonary edema. After stabilization of the patient, especially with nitrate and intravenous diuretics, this is our ECG, and I think that all of you agree that this ECG is in sinus rhythm, but with very wide QRS related to a left bundle branch block. And we perform also, after stabilization, an echocardiography, and I think that all of you will agree that this echo is not normal. There is a decrease in left ventricular ejection fraction, and if you look at the apex, we have apical rocking related to dysynchrony due to the left bundle branch block. So the first question I have for you and all the audience is, after the stabilization of acute heart failure, would you need another imaging evaluation beyond the echocardiography? And so, first you think that you have done with the echo. Second one, you need an extra evaluation with CRM. Number 3, with a cardiac CT. Number 4, coronary angiography. Number 5, CRM plus cardiac CT. And finally, number 6, CRM plus coronary angiography. And I will be very happy to know what you think about this imaging strategy.
Given that this young lady, she's in early 50s and has some risk factors, but yet at that age, probably the penetrance is less. I would go for a CMR first, and then eventually for a CT, coronary angiogram, also because there is the need to exclude a myocarditis or something that could have happened and that could have precipitated the condition as well as the left ventricular function. But I don't know, probably my colleagues will have a different approach.
So by the way, the debate is flying up here. People is heavily interfering. But before disclosing the poll, I'll tell you, this silos approach that is permeating my practice, I would first of all exclude obstructive coronary artery disease in this young lady. After all, she has cardiovascular risk factors. She's been also occasionally smoking, a left bundle branch block, and she has an additional risk factor. Let's not forget it. She's a female. And by definition, those are most of the times underdiagnosed patients. So that's why I would keep the bar pretty low and try to, first of all, do a cardiac CT. 50 years old, I do expect a good diagnostic accuracy from cardiac CT. And also because cardiac magnetic resonance is not readily available on a daily basis in my practice. If on the cardiac CT there would be no sign of obstructive disease, I would definitely go for CRM.
What about you?
Yeah, I would do the same. First, maybe we should really remind ourselves and all the listeners that there are more and more young patients coming with acute heart failure in all our departments. The data are clear. We don't know why, but there are more and more young patients. And we should not underestimate that those patients need exactly the same recommendations than a patient 20 years older, and this is often a mistake we would do. Then I would have the same strategy. I would go straight. We are lucky CRM and cardiac CT are rather easy in our institution. We would go straight for the two to make sure to understand what's happening here.
Yes, Sabine, what about yourself? What would probably this is not a typical patient you see immediately, but what is the approach in your center?
You're right. This is, of course, not a patient who would be referred to surgery first. But, of course, for me as a surgeon, the main question is there a structural problem? And therefore, I also think for the reasons you have mentioned, because of her risk factors, that an angiography might have been performed at my center.
Yes. I don't know whether we have questions.
Yeah, I was just smiling with Christophe, having a look at the poll. Do you think it is the moment to disclose the poll?
Absolutely.
So 63% of our colleagues propose to have, if I can have the poll again here. It took it away too quickly. But I think at the first place, there we go. We have at the first place CRM and coronary angiogram, 63%. Then coronary angiography, 25%. Echocardiography is enough, 13%, and CRM and cardiac CT, 13%.
Oh, that's very, very interesting. So let's see what you've done.
In fact, we did, as the majority of the audience, CRM and coronary angiography. But I agree with Alexandre and Emanuele that a CT could be a very good option. She's a young lady, probably with not too much calcification. I think the fact that the majority of the attendees selected coronary angiography could be related by the fact that in some centers it's not very easy for cardiologists to have access to cardiac CT. But I think that for this lady, in terms of, I would say, safety, cardiac CT will be the first option because we can, as we know, have coronary dissection during diagnostic coronary angiography. Okay, so we move on for these cases. So this is just what we did. So as you can see, there is no significant stenosis on the coronary arteries. And if you look at the CRM, the left ventricular ejection fraction was quite low, 21%. And I would say, thankfully for this lady, she didn't have a significant fibrosis. So the next question now, I think we have to discuss this, is about the management therapy after the stabilization of the acute heart failure. So I have several proposals. The first one is that you start with beta blockers and RICE inhibitors. Number two, above beta blockers and RICE inhibitor, you had mineraloreceptor antagonist. Number three, on top of the three previous one, you had SGLT2 inhibitors, as we call the four fantastics. Or you are a very active EP and you want to implant CRT right away without any optimization of any medical treatment. So you have still 30 seconds to vote and to let us know what will be your strategy about that.
I think I would first of all start on the 4 pillars and wait 3 months in order to decide what happens, especially for the indication for the CRT. Alex.
Yeah, Giuseppe, you're right. I mean, she's young, she has no kidney dysfunction, no therapies before, then she should handle very, very well, not only a rapid, but also an intensive implementation of those 4 drugs. We know that within 2 to 4 weeks, she can be really on the optimal dose. Probably we need to do it here in this case, although we did not understand fully why there is this myocardial dysfunction. But probably we need to start exactly like you said, at least to understand where we are going to see how the heart is going to react on those 4 pillars at the highest dose. Is she going to cope with the highest dose? Is she going to do bradycardia maybe with a mild dose? Then we need really to start an intensive strategy to understand how she's going to react, and we hope for her benefits. Yeah.
I think you're curious to know what our colleagues have answered. Well, first of all, no one would consider CRT at this stage, just to reassure Christophe.
I'm happy.
But 80% of our colleagues would go for the 4 pillars, while 20% would go for beta blocker, RAS inhibitors, and mineralocorticoid inhibitors. like aldosterone and others.
Yeah, I don't know why. I mean, this the SGLT2 inhibitors remain the Cinderella, and then you always think of them at the end. Whilst they are very safe drugs to use, I mean, they further enable the use of ARNI, ACE inhibitors, and MRAs. So I think, and also they don't have any hemodynamic effect. I mean, the effect on blood pressure is minimal. So I think we should start the practice as Alex has shown us in the strong HF. I mean, start all of them together and then up titrate gradually. So let's see what happens.
So I'm very anxious about what we done. But we did that. It was recommended in the last heart failure recommendation in 2023. We started the 4 drugs. If I may make a comment, the problem is not to start the 4 drugs. The issue is to be sure that the 4 drugs will be up-treated in a reasonable time, I would say 4 to 6 weeks. And this is a big challenge because you mentioned previously, Giuseppe, that, okay, I start the drugs and I look after 3 months, but in clinical practice, the majority of the patients are not optimized for the medical treatment. They have the same treatment as they have at the discharge at 3 months. So I think that with a transdisciplinary approach, including the nurses, I think it's very important for us today to be sure that the patient will have the optimal treatment in the shorter time. This is very, very important. Okay, so of course you have drugs, but for this lady, I think it was very important to give her some advice about the lifestyle. So of course we have to help the lady to stop smoking. We have to give statins. We discussed with this young lady with a very, very low ejection fraction, 21% at the CMR, remind you, a live vest, wearable cardioverter, defibrillator, and also for this very young lady, we ensure to have a very close follow-up to optimize the drugs. And we decided to make a new echocardiography at 3 months. So what was the status at 3 months? She has bisoprolol, say 7.5 milligram per day. This was related to the fact that she had a bradycardia around 45, 50. She has sacubitril, valsartan, the optimal dose, eprerenone, and empagliflozin. As you can see, the blood pressure was correct. She has no sign of heart failure decompensation, but she was still complaining she cannot exercise again. When she walks, she had fatigue. And so the echocardiography did show an improvement as compared to 3 months before, but it was a still depressed left ventricular ejection fraction, 33%, with a large ventricle. So for this lady with what we consider as optimal medical treatment with very wide QRS, left bundle branch block, still a poor left ventricular ejection fraction, of course we decided to implant a device for cardio-resynchronization therapy. And even if this lady has no ischemic disease, but she's a young lady, we decided to implant a CRTD, so a defibrillator, to protect her against sudden cardiac arrest related to ventricular fibrillation. So at 6 months follow-up, she is still symptomatic with fatigue when she was exercising. On the ECG, the electrical result is pretty nice with a narrowing of the QRS as compared to the baseline ECG with left bundle branch block. The electrical parameters of the device are perfect, so the device is working perfectly. But I didn't understand why this lady was still symptomatic, because when you look at the echocardiography, you see that the echo is almost normal. She has a good left ventricular ejection fraction, or 55. There was no sign of diastolic dysfunction, but this lady was still symptomatic. So I didn't understand very well, to be honest. So I asked my colleague for the heart failure clinic their advice, and they told me, I think you have to perform to to this lady a cardiopulmonary exercise test to have an objective view of what's happened when she's exercising. And you may appreciate on this slide that the baseline heart rate was 55, which is normal for a lady with beta blockers. But when you look at the peak exercise, the workload was very low, only 80 watts. For a young lady with a jogger, 50, it's very, very low. And this was related to the fact that we have a atrial chronotropic incompetence because the maximal heart rate was only 65 BPM at the peak of the exercise. So thankfully, with the device now, we can switch on the rate algorithm. And after this new tune of the CRTD, the heart rate was almost normal, 155 BPM. But look at the workload, we increased from 80 to 170 watts. So I think this was a good example of the collaboration we have to have all together when we follow patients with heart failure.
Yes. And
just to finish, a very important message. If you look at this graph, you have the patient in green. They have an indication for CRT, but they did not receive the CRT. And you can see that only 30% of the patients with a strong indication for CRT receive a CRT. So there is a huge underutilization of the device in this population. So I think that a close collaboration between all the stakeholders of heart failure will help to improve this very bad result.
Thank you, Christophe. Do you think that this data are more related to, say, a lack of referral rather than problems of in implantation?
Yeah, I fully agree with you because when you refer a patient to an EP center, usually they have the device. Because I don't think the problem is the implantation of the device. The problem is the referral of the patient to the electrophysiologist, definitively. Because sometimes our colleagues don't think about cardiac implantable electronic devices. So I think that we have still to make a huge education of the physician. And this was the program is very useful, I think. Just about all the strategy we can have for our heart failure patients.
Yes, and I think this data from the Swedish heart failure registry also probably actually overestimate the referrals because these come from specialized heart failure centers. So if we look at all patients that we are missing in primary care, in general cardiology, even before they come to the heart failure units, that probably is even, the unmet need is even bigger.
Yeah, I fully agree with that. So probably the real life is worse.
Yeah. Now, regarding your approach of putting the rate responsive device, when you do use the rate responsive, would you also reduce your beta blockers or use? Keep the beta blockers?
No, I keep the beta blocker at the same dose, and even I can increase the dose of beta blockers. Because for this patient, there was a limitation to target the optimal dose because she has already a bradycardia. So I think it's important. Your comment is very important because in some patients, we have a synergy between device and drugs. And with the device, you can optimize the medical treatment. Sometimes you have some limitation due to low blood pressure or heart rate. And with the CRT, for example, you increase the blood pressure, you increase the heart rate, and you can optimize the medical treatment. So there is a synergy between drugs and device. It's not a competition, it's a synergy.
No, absolutely. But yeah, sometimes, I mean, we see patients that complain of main fatigue. In that case, we try to reduce the beta blockers first thing and maybe use beta blockers and ivabradine in order to reduce the fatigue. I don't know whether that is shared. So I think we can wrap up this case and we can, unless we have a few questions.
Yes, actually, we've got a few questions. Certainly the first one is for you, Christophe. But from my perspective, who know very little about all these electrophysiology devices, a colleague is asking CRT-P more than CRT-D. So first of all, for those not familiar with P and D, explain the difference and when using what?
Yeah, CRTP mean pacemaker with resynchronization therapy, and CRTD means defibrillator with resynchronization therapy. I think this question is very, very good, and it's difficult to answer because, of course, this lady is young, and you know that in the Danish trial, there was a little bit a thunderstorm for the EP community because in patients with non-ischemic cardiomyopathy, there was no impact of CRTD over CRTP to improve total mortality. There was an impact on sudden cardiac death with a reduction of 50%, but not on global mortality. And the subgroup analysis did show that in patients less than 68 years old, you have a benefit of CRTD. So, but I agree with our colleagues because this patient, she has a long story of LBBB, and probably the dysfunction was related to LDDD only because we have no coronary artery disease. And what we have seen as well, that was we have a huge improvement in the left ventricular ejection fraction. So I agree that CRTP in this patient could be also a good option. It's always a case to base, but the left ventricular ejection fraction was so low at the beginning that we want to protect the lady. But very good question.
Giuseppe, I have another question, perhaps. This is more for Christophe. There is one colleague who's asking actually a common questions to both cases. What is the optimal follow-up for these patients? How frequent should the follow-up be? And most of it, do we have guidance for the follow-up?
Again, I think we had a very, very good listener here, a very top expert. Many times we heard the three of you saying follow-up of the patients because I think now it's clear that the follow-up is important. In fact, what maybe we should say even a personalized follow-up. What I mean by that? I mean by that the patients with a chronic heart failure that is fully treated, this patient is stable. We don't have to see them before maybe 9 months, a year or so. Here, the two cases are really unique cases because they come with an acute condition. Then again, red flag, I'm not doing very well. Then those patients clearly should be seen very frequently in the beginning. And when they are stabilized, when the treatment is optimal, we can really reduce the level of visits. In patients coming out from an acute heart failure episode, what is recommended today is to see them every 2 weeks in the beginning, and we should have a maximum of visits in the first 6 weeks. In the US, they said in the first 3 months. In Europe, we say in the first 6 weeks. But the idea is what? The idea is we saw that if we have an intensive starting of the 4 drugs, we can see within the first weeks, we can see an improvement in ejection fraction, improvement in the quality of life, an improvement in dyspnea. Then it's not only increasing drugs without any effect on the patient. The patient himself, they say, oh, it's totally different from what I had before. Here, I see that I feel better. Then really, in the first 3 months, they should be seen very frequently, maybe the 2 first weeks in the first month, and then we have a little bit longer period between the visits, but really in the first 3 months, we should optimize. After 3 months, the patient likely will have a very good therapy, and then we can delay.